All right, welcome to today's webinar. I'm Harpa Eastfeld-Keeley with the National Collaborating Center for Infectious Diseases, and I'll be moderating this webinar, which is called An Evaluation of One Health Surveillance of Antimicrobial Resistance. Have we moved the needle? For anyone who is new to the National Collaborating Centers, you'll want to know that we are funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. Among these 6 collaborating centers, our particular center is focused on infectious diseases, with AMR being one of our main many theme areas. I would like to take this opportunity to acknowledge that NCCID is located at the University of Manitoba on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. I'd also like to point out that we have gone blue. This blue background you'll see is a reminder that this event is part of World Antimicrobial Awareness Week, an annual campaign that runs from November 18th to 24th. NCCID hosts a collaborative awareness initiative in Canada where we share great resources and tools on a website found at antimicrobialawareness.ca. So now I'd like to introduce our speakers to you. Our speakers today are Dr. Simon Otto and Margaret Haworth-Brockman. Dr. Simon Otto is an assistant professor with the School of Public Health at the University of Alberta. He is a veterinary epidemiologist working on One Health approaches to develop scientific and policy mechanisms to combat antimicrobial resistance in the farm-to-fork continuum. He is an executive member and primary investigator in the AMR One Health Consortium based in Alberta, and the lead for the Healthy Environments thematic area for the Centre for Health Communities at the School of Public Health. Margaret Haworth-Brockman is the Senior Program Manager at the National Collaborating Center for Infectious Diseases. She has over 25 years' experience with research and knowledge translation in population health, public health, and health services policy development. She is an assistant professor in the Department of Community Health Sciences at the University of Manitoba and is also an adjunct professor in the Department of Sociology at the University of Winnipeg. And now welcome you to begin your presentations.
Thank you very much, Harpa, and thank you to the National Collaborating Center for Infectious Diseases for giving me the chance to speak with Margaret today about this project. And before I launch in, I do want to acknowledge that I am speaking to you today from Treaty 6 territory here in Edmonton, where we acknowledge and pay tribute to the traditional territories of the peoples of Treaty 6, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. So let's get started. Today, Margaret and I are presenting an evaluation of One Health surveillance of antimicrobial resistance. Have we moved the needle in Canada? And I want to acknowledge, of course, the collaboration with the NCCID and the broader team that helped with this. I'll mention Alexander Warzabowski here working, and I'll talk about other team members on the next slide, but just acknowledging all the work that went into this project. So we led this out of my research group, OHE-AMR, and it ultimately was conducted primarily by Misha Miazga-Rodriguez as a summer research assistant who developed the framework and led the project under the guidance of Dr. Lenora Saxinger and myself. So Lenora is an associate professor at the Faculty of Medicine and Dentistry here at the University of Alberta. And with support from the NCCID, of course. So acknowledging the funding for this project through the NCCID, as well as the graduate student internship program at the University of Alberta. We do want to thank at the outset the interviewees and the reviewers for the work that we did throughout this project. And just I have my disclosures there should you be interested. We thought we'd start up front just with the products out of this so that you can go to them for reference if you're interested. We were very pleased to release the full and complete report on this project earlier this year in April, where you can get a detailed accounting of everything we did, as well as some of the results and justifications for things. And to highlight that we have had the results piece accepted for co-publication between the Canadian Journal of Public Health and Canadian Veterinary Journal to really embrace this as a One Health publication for release of these results. And those items should be coming out in December or January very soon. We also were very happy to write a methods paper that Margaret led on this work that we've named the One Health Evaluation of Antimicrobial Use and Resistance Surveillance Tool, as a tool that we used and developed to evaluate this integrated One Health surveillance in Canada. So highlighting those items there should you be interested. Today, we're going to walk through the project objective and background with a bit of very brief history on two of the precursor reports that was the genesis for the work, development of the evaluation tool, and talk about specifically the results of the current state of integrated surveillance in Canada, and then a little bit about the tool itself. So these project objectives admittedly are somewhat paraphrased from the three documents, but at a high level, what we sought out to do first was to catalog and describe the scope of the current federal, provincial, territorial AMR and AMU surveillance programs in Canada relative to the 2014 NCCID report on the topic. You'll note that there's no specific objective for development of the tool within these two things, but as we began the work, Misha noted in 2019, there was no published tool at the time that was fit for purpose for the type of evaluation we sought to complete. So he developed that tool so that we could complete objective number 2, which was to evaluate the current status of integrated AMR and AMU surveillance in Canada, compared to the gaps that were noted in the 2014 NCCID and 2016 CCVO reports, and then to highlight future potential directions for integrated surveillance in Canada. I'll pass it to Margaret now to talk about the 2014 report.
Yeah, just briefly, NCCID's involvement in the subject of antimicrobial resistance, antimicrobial use, and antimicrobial stewardship has quite lengthy. More than 10 years ago, for instance, NCCID was part of the initial Antibiotic Awareness Day movement, and as Harpa has already described, now fully involved with many, many partners across the country in the World Antimicrobial Awareness Week here in Canada and elsewhere. And part of the long history of our involvement in interest in AMR is that our scientific advisor, Dr. Alan Ronald, commissioned a comprehensive review of AMR surveillance in Canada and comparison to international surveillance programs. That report, which was led by Lenora and others, was released in 2014 on our website. At the time, the recommendations that were part of that initial assessment were not included with the report due to the political will of the time, but were available. And now you can find the core recommendations alongside the full report. Those core recommendations served as a foundation for this current review. And if we next slide, Simon. And as well, Simon and his team were looking at the core strengths and the identified areas needing development in Canada. So in a nutshell, Canada was hampered at the time, and may still be, by being geographically vast, culturally diverse, with multiple jurisdictions overseeing public health and government, as you know, that there are gaps at the time in 2014 in the current surveillance, but there were some sound elements that addressed aspects of the surveillance that were needed. And an overall recommendation was to align and combine the existing provincial and federal surveillance resources for cohesive, integrated, and accountable surveillance that would really capture the state of AMR across the country. Next slide. Since the time of the release of that report in 2014, NCCID and colleagues across the country have been involved in a number of further steps in evaluating and monitoring the progress of antimicrobial resistance, surveillance, and other aspects. There was the federal framework that was released later in 2014, and an Office of the Auditor General report, followed by a federal action plan released in 2015. Work towards a Pan-Canadian framework was completed in 2017, and work towards the Pan-Canadian action plan was nearing completion at the beginning of 2019, but was held up by the arrival of the pandemic. But in January 2019, NCCID was a co-host of a stakeholders meeting held in Ottawa. Simon and others were there, and we had a chance to talk about a One Health approach to AMR surveillance, that in human health, animal health, and quite a bit of discussion about environmental issues. And so it was at that meeting that Simon and Lenora and I determined that it might be helpful to understand what is the state of AMR surveillance in Canada now. Thanks, Simon.
Thank you, Margaret. The other piece of work that was going on at similar time was the Canadian Council of Chief Veterinary Officers had asked the Antimicrobial Use in Animal Agriculture Committee to evaluate the status of non-human AMU surveillance in Canada. So I co-led this working group and committee with the list of people you see there on the slide that did a thorough comparison of what Canada currently collects for use data in animals compared to other countries, and then ultimately to make recommendations on how we could improve that and enhance that in Canada. So the group, Jane Parmley, I think, was one of the starts of this, and really it was a great way to lay out the different sources of antimicrobial use data available for surveillance. Looking at the three models that we presented in that report: sales and distribution data, data at the veterinary level from records and distribution, and then ultimately purchase and owner and producer data, and looking at the relative ability to measure granularity in use, as well as the difficulty and effort required to do so. And where we landed with this ultimately was that we did not have a clear policy direction to provide objectives for what that surveillance should and could look like. And our recommendation back was to say, these are the options, but we can't tell you which one that we need to use until we have some clarity about what the objectives for the program would be. And the two that were proposed were, broadly to educate stakeholders through information, or perhaps to direct use in animals through more direct policy or regulation, and that these things needed to be addressed. So those two reports served as the foundation of the surveillance status at the time and the recommendations that we should have moving forward, which I'll get into here in a bit. But we'll move into the methodology and the pieces that Misha put together as he went through this work, working very closely with Lenora and I through the process. So we'll talk about the evidence piece, the evaluation, and then ultimately how this landed into results and conclusions. Misha started with a literature search in May of 2019, using Google, looking for evidence of active AMU and AMR surveillance programs at the federal, provincial, and territorial levels. Reviewed the documents, as well as, not just the literature search, but informed by the knowledge of the investigators on the team, and really highlighted these programs that included things like antibiograms, reports of surveillance data, and potential dashboards. From there, he conducted interviews to really fill some of the knowledge gaps that he identified in the literature screen and review. So we identified and interviewed key experts from across Canada at the federal, provincial, territorial levels to fill these gaps, and ultimately based on our knowledge of the environment and the people and the networks that we had. As part of these, it was an open-ended interview that allowed for a lot of exploration, and we also asked the interviewees to identify additional people that we should be talking to fill these remaining gaps, and we conducted those interviews with all of the experts identified that responded with consent. So when Misha got into this, as I mentioned, at the time, there was really no published tool suitable for evaluating an integrated One Health AMR AMU surveillance program. So the first thing that we did as a team was to really identify and adapt the core surveillance requirements from these two reports into things that mapped out to 8 broad surveillance requirements. With a number of subcomponents within. So we took the details from those and landed with these core 8 requirements for an integrated system in Canada. So it, broadly an integrated resistance and use system, increased resources for resistance and use surveillance programs, a national AMR data warehouse, national human surveillance, national animal surveillance, collection of AMU indication data, timely and integrated national reporting of resistance and use data, and lastly, a formal recognition of One Health policy for stewardship. Within those, there were 36 specific components that mapped to the different 8 requirements, and you can see those details in the full report. So while we recognize that truly integrated One Health surveillance for AMR, AMU must be integrated and include all these parts, it's not lost on us that the environment in particular is not included in the list of 8 requirements that you see here. The environmental evaluation piece came in under the national animal part, but I think we recognize that the environment still does represent a gap, both in evaluation as well as moving forward. If you review the 36 components, you'll see that environment is included there in some ways, but it's not its own overarching requirement as it was set up here. But I want you to know that it's not ignored in this piece as well. And I will admit, and we'll see in the gaps at the end, that considering human sewage, for example, is something that was not part of this evaluation and should be moving forward. The other important thing we want to note is that some of these components do not necessarily need to be One Health and include all sectors for everything. There is still a need for human surveillance of use to inform and for resistance to inform use, for example, but the integration across sectors where appropriate is important. Misha then went into the literature and found 2 tools that were existing for various purposes that we then adapted and made our own for our evaluation tool. The first was this publication by Shell et al. That looked at a broad framework and system for evaluating the sustainability of public health programs broadly. So the sustainability element looked at in that paper 9 different pieces that they evaluated. We adapted these 9 areas to be fit for our purpose. So the 9 are on the left there, and we see the 7 that we ended up using: funding, organizational capacity, partnerships, program adaptability, communication, strategic planning, and enabling policy. We determined that the public health impacts was beyond the scope for us, given that the Council of Canadian Academies was working on socioeconomic impacts of AMR at the same time. And we didn't feel that we had the data to evaluate the question of political support, so we adapted that to enabling policy. And strategic planning was also couched to include the program evaluation component. The next piece was to develop a rating system, and this was developed and modified from a publication in the British Medical Journal that was developed as a World Health Organization situational analysis tool to quantify the 5 stages of program development for countries that were striving to develop AMR action plans under the WHO Global Action Plan. So with this, we developed the 5-point scale, which we'll see in a moment. So ultimately, these 2 pieces came together into this 2-way evaluation matrix. So we've got the common program sustainability elements down here on the left that I mentioned, and then we've got the 5-point ranking scale across the top. So 1, exploration being the lowest level of development, up to 5, sustainable operation being the highest level. And we developed definitions for each of these for funding. What does exploration look like versus sustainable operation, for example? The definitions of these things were created iteratively with the team, in that we put them together, and as we were going through the evaluation, we realized that there were parts of how they were put together that needed to be clarified to have really clear-cut and objective delineations. And so if we made a change, we would go back and look at everything again. And in the end result, so we have these 7 program sustainability elements, which were applied to each of the 36 components. And I'll go through that more in a minute. So we then we've got our broad 8 requirements in the black bars, and then each of the components underneath of them. And we rank each of those 7 sustainability elements with the legend that you see here on the right, to go through and get a sense of the overall patterns in terms of stage of development for the different components. The other thing we did, we completed this initial evaluation towards the end of 2019, and in December 2019, January 2020, we sent out our current results with some key questions to subject matter experts that were part of our interviews and broader teams to review our assessments for validity. So we inquired with members of CPARS, CARS, the co-chairs of the surveillance task group of the FPT AMR steering committee for the action plan, the co-authors of the 2014 NCCID report, and the NCCID sponsors. They did highlight some areas for adjustment that we needed to consider, and they also highlighted a few components that we had missed as we put it together. And so adjustments were made as applicable, but there were times where the subject matter experts disagreed with our assessments. And in the end, we went with our final assessment and provided justification for that available in the full report. So I'm going to pass it to Margaret here before we get into the results.
So thanks, Simon. Just to recap the methods that you've described already, this One Health evaluation for antimicrobial resistance and use begins with the 8 overarching requirements that were consolidated from the CCVO report and the NCCID report of 2014. And under those 8 overarching requirements are 36 components with different numbers of components within each of the requirements. Each of those was then assessed for its sustainability under 7 possible levels of sustainability or sustainability capacity per shell, and then also assessed for the ranking of the stage of development. So not only how sustainable they were, but how far along in development they were. And as Simon said, then were reviewed by experts before a final ranking was applied and giving us the final results. So just a note to say that this is a new tool that was created from the 2 previous ones. Neither quite got to the complexities nor the granularity that Simon and his team were looking for. And that this method was developed before the new projects under the CoEval-AMR international team were being produced and now publicly available on their site. So I'm happy to say that this new tool will be part of that.
So the results in the following slides are focused on our evaluation of the national surveillance programs. We did not evaluate all of the specific provincial territorial entities that were part of it. Where appropriate and applicable, the inclusion of the provincial territorial data were included in the evaluation of the national program, because there are cases where the PT data do roll up to the national level, but we didn't evaluate each of the provincial territorial programs on their own. There are a lot of examples of program components that are working well, but when we roll the components up to national programs, the evaluation shows that programs are not as far along as we would like in some cases. And this is often due to limitations in scope and adaptability of the programs themselves. This figure is meant to show where so we have the interview responses as well as the programs that were considered as part of this. So we reviewed 6 national programs, 20 provincial and 1 territorial programs were considered where applicable and looked at. We conducted interviews with 28 subject matter experts out of 33 invitations. And there's a lot of details on that slide there about surveillance programs, human versus animal, and other things, which again, available in the report. Our results end up in these heat map-like figures of the valuation rankings, and I'll show a picture from the 2014 NCCID report to give you a sense of where the initial idea for the heat map came from. As I've mentioned, the final assessments for each of those components with justification for why we chose the rankings are available in a downloadable spreadsheet with the NCCID report that really gets into the nitty-gritty of things if you're interested. Generally, we found that the overall trends for the key requirements of overall integrated surveillance are largely in the lower stages of sustainability, exploration, and program adoption. So requirements 1 to 3 in particular illustrate this when we talk about a national integrated program, the resourcing piece, as well as the AMR data warehousing piece. We can see that a lot of those are in exploration and program adoption. When we consider some of, and the other piece there as well that had, a little more advanced, but had some areas that needed to be improved were in the timely and integrated national reporting of data, as well as the formal adoption and recognition of One Health policy for antimicrobial stewardship. When we look at existing programs in orange, in particular CNISP and CPARS, we can see this is where there are elements that things are further developed in terms of sustainability. So the Canadian Integrated Program, the Canadian National, Canadian Nosocomial Infection Surveillance Program, just about got caught there, and the Canadian Integrated Program for Antimicrobial Resistance Surveillance. And so again, the components of each of those are listed in the reports. But there were some real positive advancements in sustainability development for some of those components. And then down at the bottom, the last 3 policy elements were the changes made to importation loopholes for antimicrobials for use in animals, as well as the move of medically important antimicrobials to the prescription drug list. So just as a comparison, this is this heat map concept and idea from the 2014 NCCID report. And again, there's different criteria there, but it would just really helped us visually to look and see how the results played out as we put these things together. We also tried to use these alluvial diagrams to show an ideal scenario in this case versus the scenario that played out with our evaluation. So in this hypothetical example, we can look at surveillance components on the left here and look at their rankings. So we take each of them through the 7 program elements and then look at their stage of development rank. And so in an ideal situation, these program elements would ultimately align in the sustainable operation category for most or all of them. What we found for component recommendation 1, for example, a national integrated program with its subcomponents here of an integrated system, standardized metrics and indicators, and integrated provincial territorial initiatives, is that the majority of those program elements for each of them ranked in exploration, program adoption, and initial implementation. So the lower stages of sustainability, whereas we had none that were in those higher levels of sustainable and full operation. Similarly, when we look at requirements 2 and 3, 2 being the resources and funding for a multi-sectoral plan and system, and then 3 being the AMR data warehouse, again, we can see that a lot of them resulted in exploration and initial implementation program adoption, as opposed to a relative few in full operation and none of them in sustainable operation. So again, just coming back here now to requirements 4, 5, 6, 7, and 8. So again, the overall trends again for CNISP and CPARS that we do see more of these components that are in sustainable operation and full operation. There are some elements here that are in exploration, which the further details are available in the report. Things like community long-term care surveillance, northern remote and indigenous communities. And then down in the animal piece, if we look at some of the farm commodities that aren't or weren't represented regularly at the time of. And we've mentioned some of the policy elements down below here as well. So key findings. In 2015, the Canadian AMR Surveillance System, or CARS, was created to integrate antimicrobial resistance and use data. CARS itself serves a data integration and reporting function, and they have improved the timeliness of reporting of the data for sure. But they don't collect new data, and they don't represent a national surveillance program that is truly integrated across the One Health sector. So we are still lacking this comprehensive integrated program. We noted the positive expansion of components within the existing national programs, CNISP and CPARS. However, a lot of these new additions, such as the beef surveillance program or some of the work in community and northern communities for the human side, are still based on time-limited project funding and leave some important gaps. The community hospitals, the northern surveillance and Indigenous community piece is being explored and new things rolling out under CNIS, but there are still large gaps and a particular lack in long-term care on the human side. The CPARS components include increasing numbers of farm commodities. There are still gaps, but there's also the point that they do represent a relatively small number of farms based on what's out there in Canada. And we know that there are real gaps and non-existent data for veterinary pathogens on the animal side. Throughout some of the interviews, there was a lot of discussion about AMRnet as a promise for surveillance to bring together antibiogram data on the human side and potentially the animal side, and that this is evolving, but it's uncertain the current status of this in terms of funding and ability to move forward. So I've already mentioned that the representation of human resistance and use data in community settings and long-term care in Indigenous communities in rural and northern Canada is still quite limited in the system. The current provision of human and animal data, for that matter, from the provinces and territories is voluntary and non-standardized. All but 2 of the PT programs focused on human surveillance with AMR data from animals in Quebec. The animal programs themselves are expanding, but are still based on this relatively small number of sentinel farms that I mentioned. And we have inconsistent animal commodity species coverage on province. And that's partly by design based on the main commodities that are there. A lot of the AMU data on the human side are provided through IQVIA, which again are based on a relatively small number of pharmacies and physicians to represent the whole country. And also just the fact that we are relying on third party to provide these data does limit the adaptability and some potential uncertainty for long-term contracts for availability of those data. We've mentioned the question and concern about the different roles federally and at the provinces and territories and how we standardize data. So when you look into the documents that lay out the roles in the AMR framework, for example, the federal role is surveillance of infectious diseases. The provincial and territorial roles are broader in terms of managing surveillance systems at the provincial level, establishing and implementing the regulations around antimicrobial use, for example, both on the veterinary animal and the human side, and quite broad. And we know that, for example, healthcare and public health is rolled out and managed at the provincial level. So this creates this challenge of who can and will ensure that the PT systems can contribute to national data surveillance in the area where AMR is the next slow moving pandemic threat. And how do we do that in a standardized way? Do we need policy mechanisms to compel standardized reporting so that we can put these together in a meaningful way? A lot of the reporting sits at the intersection of FPG jurisdictions. And so there currently isn't that PT requirement to report. And that really the coordination and funding of this is a potential nightmare. We realize that, and that's not going to change and something that we need to deal with. And it's no surprise probably to anybody on this webinar today that that's something that we need to deal with, especially as we move towards the next iteration of the action plan that was waylaid by COVID. This is something that really needs to be considered in the governance structure for the whole thing, and specifically around the surveillance piece. We found that the tool that we developed really was well suited for the assessment of integrated One Health surveillance programs. It allowed a granular assessment and really for us to get into the details to look at specific items. We note that Canada has made incremental progress within these existing programs to improve integrated surveillance within the existing patchwork, and the development of CARS has improved that integrated reporting piece, but noting that the CARS report is a subset of data. If you want complete animal data, for example, or farm to fork data, you need to go to the CPARS programs. Most of our subject matter experts agreed with our evaluations, and the differences were largely based on interpretations of representativeness of existing program components. Overall, we still lack this truly comprehensive national program with significant gaps and delays in reporting in some of the areas. And just noting a policy or a paper from Van Katwick et al. In 2020 that noted in a line that Canadian policy efforts to address AMR are disjointed and inadequate at the time, and we know that there up until now have not been large investments at all really in surveillance infrastructure and AMR as a whole, and we read a little bit about that in our report and the papers that are coming out. I think the AMR net funding and the project holds some promise if we can get there, but it's still unclear where that's headed as we move into this. So we highlight really 3 critical areas for action to move the needle further on this. Number one is we know we need to develop this complete integrated surveillance program for AMR and AMU that expands on the current success. We're not advocating getting rid of what's there. We're advocating expanding it and ultimately resourcing it appropriately to make it successful. We strongly feel that changes in the FPT policy structure to compel autonomous but standardized reporting would really be helpful. And I know Lenora has done some reading and suggested perhaps that a managed network model might be the thing to change the status quo. And as we've said before, and in no surprise, investment in resistance and use surveillance resources is paramount. Dedicated personnel, funding, and enabling policies and structures to do this. I think now I'll pass it to Margaret just to talk a little bit about her perspective on the tool.
Yeah, just to recap on the tool itself, the One Health evaluation. NCCID's mandate, as I've already noted, is to provide information in usable formats for public health audiences and policy that can inform good public health programming and population health. And the value of this tool as we see it, it is very granular and will allow for repeatable assessments of the surveillance programs as going forward. It provides a transparent platform that is flexible and adaptable. So where we've noted that human environmental surveillance is not yet included, genomics not yet included, those should be able to be fairly easily incorporated under new or existing components. This allows really for an assessment of a very messy set of systems as described by Hunter in a complex and wicked problem that's facing us all. It should be adaptable to evaluate any singular aspect of an AMR, AMU surveillance or the multifaceted, multi-jurisdictional systems that we have now. The only other thing I want to comment on, just so we don't lose that thought, Simon, is that the AMR net that may be under development at NML is distinct from the AMR network, which released its first report in July of this year. I'll send it back to you.
Thanks, Margaret. Yeah, it's important to make that distinction for sure that, the two are different entities. And the AMR network really, they've put out their report looking at governance models of how we manage this in Canada. And I think, looking at the pieces that have been put forward, I think we're all curious and waiting anxiously to see where that goes with respect to the future development of the action plan. So we mentioned the future considerations here that Margaret's alluded to. I think one of the things we realized for some of our assessment of components was that we were lacking an assessment of the true scope of surveillance components. If we take an on-farm component under CPARS, for example, it's included there, but what is the scope of that component? Is it truly representative of what we need at the Canadian level? And that's something that would be a next step for this. And that would apply on the human side as well. We included some of the animal environmental factors, such as crop surveillance data, increasingly looking at some of the aquaculture pieces. but realizing that our evaluation had gaps for things like human environmental surveillance in wastewater and sewage, but we also knew that those things didn't exist at the time, but really those would be requirements for a future system. And I think the third piece is the role that genomic surveillance will play for antimicrobial resistance genes and how we can incorporate genomics data in understanding that there's sometimes a disconnect between phenotype and genotype and what that really means. We mentioned the CoEval-AMR network, which is a network that it's an international piece that has a strong Canadian contingent. So we presented this work to that group at one of their seminars a month ago, but really wanted to highlight the work that they have put out in the meantime, so in a paper there on evaluating integrated AMR surveillance and ultimately an integrated surveillance system framework for evaluation of One Health programs for AMR, AMU. You know, their objective is to, there is convergence and evaluation frameworks for integrated surveillance of use and resistance. And they want to develop and make available guidance for the evaluation of surveillance for these things that will address the specific needs of integrated systems. The project comprises networking, sharing, and learning activities, research activities, evaluation case studies, and disseminations. And their results allow understanding of the potential value of integrated surveillance for resistance and comparing surveillance strategies across countries in order to identify the most cost-effective approaches. So they're working with funding from JPI AMR and includes members such as the Université de Montréal, University of Guelph, Ottawa, Waterloo, York University, and a broad list of institutions in Belgium, Switzerland, the UK, France, Italy, the Netherlands, Norway, Senegal, the US, and Vietnam. So we're really looking forward to ongoing discussions with them about how we can be a part of what they're doing, and also to know that they are including our tool as a potential within the future work that they are doing. We really, again, thank you to the NCCID for the opportunity to present today. Thank you all very much for your attendance. We'd be happy to take any questions, and just a shout out again for Antimicrobial Awareness Week and recognizing the importance of this.
Thank you, Simon. Thank you, Margaret. Wonderful presentation. Some very systematic and orderly thinking applied to the messy problem, and appreciate this work. So I'm going to go to the Q&A. Please, if you have questions for Simon, for Margaret, please type your question into the Q&A pod. So you should see the little two Q&A bubbles, and for our presenters that's distinct from the chat that we have. So I'll go to the Q&A. I don't yet see any questions, so please, I see we have about 15 minutes left in our event, so do follow up there. We do have the advantage of a few questions shared in advance of the event, so I'm going to begin with those and keep an eye to the chat pod. So the Public Health Agency of Canada has recently initiated an AMR task force to continue work on the Pan-Canadian AMR Action Plan. Where do you think its priorities should be in the area of surveillance? That is at a federal and provincial territorial level. Simon, could we ask you to begin?
Yeah, thank you, Harp. I'd be happy to. We've alluded to some of that, I think, in our conclusions, that this fact that a lot of the data collection and synthesis happens at this, this right in between, at the juncture between provinces and territories and the federal government. So really having those meaningful discussions about governance and figuring out ways to try to automate or to require reporting from the provincial territorial level up, but providing resources so that they can do that effectively, and giving the guidance for standardization. And I think AMRNet does hold promise in that regard about how to put antibiogram data together. But I also know, we've got colleagues in Alberta, for example, in the AMR One Health Consortium that are working on developing a provincial antibiogram, and it's great work to see that moving forward. So how do we integrate that good work with similar work in other provinces and territories and be able to utilize that data at a national level for national surveillance? and the other piece is, the broader FPT governance around the action plan and the responsibilities that are going to come out of that. And ultimately the funding, the resourcing, people, places, resources is going to be a big key in how that's going to roll out. Margaret, did you have anything you wanted to add to that?
Well, I just want to add that the federal agency has provided leadership all along. Sometimes it might have seemed limpingly so, but I think we've come a long way from 2014, 2016 in terms of attention to AMR and AMS. Sidelined for now by the COVID pandemic, and I think that is why the extra resources and sustainability will be needed under the leadership of the agency, because it seems like such a monumental problem, and we have climate change and the current pandemic in the news and in the headlines, more pressing concerns. So that leadership will, as Simon has said, will be essential to convene meetings and allow for sharing of information, and then providing some genuine support in terms of sustainability for ongoing surveillance and stewardship programs.
Thank you, Margaret. And I see a question in our chat pod. You highlight that many of our surveillance efforts use sentinel sites that are likely insufficient. How comprehensive is enough from a cost effectiveness perspective? What metrics can we use to make these decisions? Simon, can you comment on?
Yeah, I'd be happy to start there. And I think it goes back to the work we did for the CCVO that, that report in 2016, is that right now we are largely using those surveillance data as an educational tool to inform what do we know, as what we hope is a reasonably representative sample across the country. And so if we're using it with that in mind, then we don't need everything. We don't need the census of every farm, of every veterinarian. The challenge becomes is when we start to see disconnects in the data. And I've been involved in a couple of analysis projects recently where we see some potential disconnects between different sources of data for industry level versus what's in CPARs. And then we start to ask, why are they different? And, potentially different populations, how representative is good enough? And I don't know that we know what that balance point is yet. I think we're realizing that there is space now to go and look into some of those things to figure out where the disconnects are. The ultimate reality is that's based on a system of education and providing information that we can use to inform policy development and educate producers and veterinarians. But if we were to be forced into or have to go down the road of something more strong to regulate use should international trading partners require us to do so, then we're going to need a lot more farms, veterinary clinics involved in the surveillance data piece itself to be able to understand data more granularly. I think that, and we don't know what that looks like in the future going forward. We just know that there are changes afoot in international regulations that could require us to have a more detailed picture of use. So I know it's not the best answer to your question because it's hard to really commit to that, but those are discussions that still need to happen.
All right, thank you. And just drawing on some of our other advanced questions, you mentioned that a next step is to consider the scope of the components. Can you please explain this?
I alluded to it a bit in my conclusions, and I think the Sentinel site piece is a really good one, right? We know that the number of, for CPARs on farm, the swine program, the broiler program, the turkey, each province has a limited number of farms that are participating, and that's partly dictated by the numbers of farms willing to participate, the time of the veterinarians to do it, as well as the budget that CPARs has to roll those things out. So evaluating the scope would be part of a even more granular consideration of, okay, how many farms do we actually have in the swine program? We know that the swine program, for example, also includes grow-finished swine at this point and doesn't include the whole production cycle. So those are things that we could get more into the weeds on the scope of the different components to see and give a more formal evaluation of that as almost a third layer to this whole thing. The other piece would be, a good example on the human side is some of the long-term care and things as well, to figure out what's available, how much are we actually looking at across the country, or the representativeness of the IQVIA AMU data, for example.
Right, and I think to pick up on that, on the long-term care side is a question. When we think of AMR surveillance in human health, we tend to think of hospital sites. Is there a role for long-term care facilities to contribute to community-based data? Did either of you want to take that one?
You want to start, Margaret?
Margaret?
Well, I think it's certainly worth looking at. These sentinel sites, for the most part, are in hospitals, and even the expansion of CNIS will be, because it's nosocomial infections, will be in hospital or nursing station sites. But we also know that the frailty and vulnerability of residents of nursing care and long-term care means that resistant organisms do spring up, and we don't really have a solid way of including those data, nor working yet with the administration of those facilities on capturing that data. And often it gets translated into hospital data. So I think the importance is to tease that out a bit as best we can to understand the risks for those who are sometimes being moved back and forth between facilities.
Simon, do you have anything to add there?
Yeah, and noting that, you know, we saw that there were CNISP expansions into some community prescribing, recognizing that, you know, when you look at the AMU data, the majority of antimicrobial use prescriptions come in the community, not in hospital settings. And so that's an area that needs to be looked at, and that there are, as we said, some developments in CNIS to bring in some community use and resistance data, and some work with communities in the north in particular to bring in rural, remote, and indigenous communities. And those are starting points for sure, and things that need to move forward. You know, one of the other things we noted in our work was that in the void of data, sometimes in these spaces, we've seen the proliferation of various point prevalence surveys at the hospital level, for example, to try to fill some of these gaps in human AMR, AMU data. And so we get these sometimes competing point prevalence surveys that are collecting data in different ways. And it can be useful, but if it's not standardized and they look different, then it's hard to really bring those into national surveillance. And again, some of them have come about because there are gaps in the system to collect these data otherwise. I see in the Q&A there a comment about it'd be great to run the tool for the AMRnet plan, and whoever has posted that, we'd be really happy to have that discussion. So please follow up. I'd love to. It'd be really interesting to use the tool kind of preemptively on something as it's being designed, as opposed to after the fact. I think that would be really neat.
We could also go to the next question in the pod. Is there a plan to bring in data from veterinary clinics working with companion animals as well?
Thank you for highlighting that. It is something that I forgot to mention running through the results, that the companion animal piece is largely a gap right now. I don't know that there's a formal plan. I know that there's discussions knowing that that's a gap. I'm not sure that I'm completely up to speed on how that's going to happen, but I know there are people across the country that are starting to look and talk about that. I know Scott Weiss and others, and we've had a few project proposals trying to look at that. Not gets traction yet, and we're looking at ways to do that. You know, I think with some of the changes in the corporate environment for companion animal practice and some of the centralization of records within larger entities, there's some potential to maybe look and use those as pilot projects to understand how we could collect data. But I know others in the country have done some work at how you harvest veterinary record data as an example, and realize that it is incredibly complicated and sometimes fraught with gaps as well. So there are things out there that have been started, but I'm not sure the current status for plans with others in that space.
Right, and I see I suppose that's Mike Mulvey. AMRnet is doing this. Mike Mulvey, that's another question there. So.
Thanks, Mike. As I'm assuming your comment is specific to the companion animal piece. And that's great to hear. You know, it's something that we definitely need. It's a major gap that was noted.
Yeah. On the topic of another gap, you mentioned wastewater surveillance briefly. Are there other aspects of AMR in the environment that could fairly easily be incorporated in surveillance programs?
Easily is maybe a loaded term, but importantly, yes. I know other countries, and I think Canada's starting to look at the wastewater piece as a potential to understand resistance and sometimes use in terms of residue surveillance as well. And understanding that, it's a big picture approach we need to take to this. We've got crossovers. We know that wastewater coming out of hospital environments is important, for example, but we also know that, human sewage sludge could get spread on agricultural land, or animal manure could get spread on agricultural land. And so these all create transmission pathways for resistance determinants and organisms that we need to consider. And just a bit of a plug for some of the work that I collaborate with on at the School of Public Health, led by Dr. Norm Newman's lab, that's starting to look at, for example, wastewater resistant strains of bacteria. So his lab has identified a strain of E. coli that is highly resistant to wastewater treatment mechanisms like UV, ozonation, and temperature. And these organisms tend to harbor a large number of resistance genes as well, but some disconnect between resistance phenotypic expression. But they also have discovered that these wastewater specific organisms develop independently in different sites in the world, and that they're also closely related to some human pathogenic E. coli like UPEX and for urinary pathogenic E. coli. So it's really caused us to think and start to try to understand what those broad transmission mechanisms are between these things. Should we look at wastewater reuse, for example?
All right, thank you, Simon. I do see we have just 3 minutes left in the session, and I see another question. We are identifying a big difference between IQVIA human AMU data in Newfoundland and Labrador and our own more representative pharmacy network AMU results. That's from Peter Daly.
Peter, that's really interesting. I think, I mentioned it. I think it's one of the next steps for this is as we look at different data sources and, we make that plug to try to put PT data into the federal piece, is we do need to try to explore why these differences exist, right? What is the difference in representativeness if we look at these data sources? And the IQVIA versus your local pharmacy network is a really interesting piece and something really worth exploring. And I've mentioned some other examples. And then I see Mike's comment there as well. Maybe the silver lining of COVID, if we've now developed the wastewater infrastructure for SARS-CoV-2 out of necessity for surveillance. And so it's something that probably people had ideas to do work with AMR, but we didn't necessarily have the infrastructure in place. So now we've got it, and let's continue to capitalize on that. That's really interesting, Mike. Thanks.
Harpa, I'll just add for the environmental sites as well to what Simon's already said, that I recall from discussions in that January national meeting, January 2019, that water sources, which of course are part of the cycle of wastewater at some point, but where there are boil water advisories was flagged as an opportunity to look for resistant organisms. And that is something that might be an easy win as well.
Thank you for adding that, Margaret. All right, I see no further questions. I maybe have one last to pose.
Just thought of a comment to add to follow up maybe before we jump into something else, because I think it's relevant to the environmental side. And I've heard others mention it, and a few people in Canada and otherwise have starting to write about what the impacts of COVID-19 could be on antimicrobial resistance. And I think there is a real need, and people are starting to look at this about how do we look at the surveillance for resistance to environmental disinfectants, alcohol, other things that we use in our environments. I mean, use of those products like that have been widespread in intensive agriculture for cleaning and disinfection, for example, in barns between phases of animals. But with all of the cleaning and hand sanitizers and things that we're now using as a result of COVID-19, definitely create some questions about what the selection pressure is going to be for antimicrobial resistance. And then just knowing that, that the use of antimicrobials in all those intensive care patients as well, and understanding, I mean, there's been some real differences in some of the literature now about antimicrobial use dipping in community because people are going to the doctor less, and really digging into some of those social components and environmental components for resistance will be interesting and important as well.
That's wonderful food for thought, and I see our time is coming to an end, and I'd like to thank both of you, Margaret, Simon. Thank you for sharing this work. It's expansive and terrific to also hear from our participants today about the work that's going on in your realms. So thank you again to our speakers. And thank you to all of you in attendance today. Have a terrific day and a wonderful antimicrobial awareness week.